One of the other things I didn't like about the other devices is that I was sucking out a lot of blood. And, I wish these patients ended up being normal and then coming in, but a lot of them are anemic at baseline. And when you take out a lot of blood product from them, now you might have saved their leg, but now they don't feel very good. They get tired, fatigued, a lot of those kind of things. We don't want to transfuse if we don't have to because it's a quality marker. So what's your experience been with Pounce? Do you think you removed less blood than with the devices that are aspiration based?
Oh, for sure, because you're not having to remove a bucket of blood to get some clot. With that said, however, the hygiene of sheath maintenance is really important, and sometimes you do have to lose some blood to make sure that you have removed all the clot that may be in your sheath before you make a subsequent pass. And so with that, I'll purge the sheath, I'll make sure it's clean. And so I do, it's not a bloodless procedure, but overall, the overall waste is minimalized compared to comparative devices.
And how does that change your thought process during the procedure? Sometimes there's a balance between clot removal and blood removal. Has that changed with the Pounce, or how can you explain what I'm meaning by that?
When you see an occlusion, you have an intuitive sense of how much clot you should be able to remove. And with each pass, you're making a judgment call as to how much was there initially, how much did I remove, and how much residual do I think I have left. And so that's part of the learning curve. The learning curve's fairly intuitively obvious. Okay, I think I've got the bulk of it out of there. I just need another pass here or two to clean up the rest. So there's so many things that you take into account as you're trying to get to the end or make a decision. I've done enough. And I've found that if I make that one more pass, I'm much more happy beyond actually reestablishing flow.